this is just some photos of the team. We've managed virtually everyone in the team between the photos, so we were quite proud of that. Our background to this project was very much that the data from 2018, 2019 showed that in terms of getting HbA1c checks, so 4 or more in the year, we only achieved 44%, which was below the national average of 57. In addition, our adjusted mean HbA1c for that year was 70.3 millimoles per mole, which is higher than the national average of 65. And so as a result of this, we were deemed on the NPDA data to be an outlier. And this just shows the data from that NPDA study where we both achieved lower measurements of HbA1c, and also this is us in blue here, our proportion of children with an HbA1c over 69 and above was higher than both the East of England and the national data. And so our aim, as said before, was to improve the HbA1c for children and young people in West Hert. This was obviously a great initial aim, but then the pandemic hit, and we realised that actually even before we could work on improving HbA1c for our young people, actually our first challenge was measuring our HbA1c. As I'm sure you're all aware, due to the COVID-19 restrictions, there was a lack of face-to-face contact where we traditionally did our HbA1c tests, and West Hert and our hospitals here were very strict about not bringing patients to hospital due to guidance on reducing footfall. So as a first step, we had to come up with ways to measure HbA1c. The first trial was a drive-through, and we went through various sort of PDSA cycles, which I've not detailed here. But the first was the drive-through check, and this was literally using the COVID-19 tent at the bottom of the car park was initially done. And this worked fine while the weather was good. And then we discovered that our HbA1c machines were a little temperamental and don't like cold weather. And it was also not so pleasant to be in the dark by yourself at the bottom of a car park. So this was then moved into out of a window of outpatients. So we're split over 2 sites. So in our outpatients at Hemel, children could come to the window, parents could park in the car park just outside, children could come to the window, stick a finger through a window and have their HbA1c measured with the machine happily kept warm inside. And this stopped them coming in, but it still meant that we could actually measure our HbA1cs. This carried on for a few weeks, and then we reviewed this. What we found very much was, while this worked very well for our patients who lived in Hemel and in St Albans, for our Watford patients, which is about half of our caseload, a lot of them, for various reasons, reluctance for public transport, no access to cars, found it quite difficult to get to Hemel, which is about 15 miles away from Watford. So we were missing a large proportion of our caseload at this point. So then we introduced specific HbA1c clinics, and this was as things were starting to open up a little bit. We were still not really allowed to have face-to-face clinics, but there was allowed to be a little bit more footfall through outpatients. And so then we opened up clinics both at Watford and at Hemel, still through a window in Hemel. In Watford, that wasn't allowed. So patients could literally pop in for about 5 minutes, have a finger prick, and then come out. And actually, we found that this worked quite well, and there was quite an appetite for this from patients and their families. And this just kind of shows some of the data that we got from there. So in blue is our first tests, and you can see that when we started this process, actually we were getting quite a few tests a week, which peaked kind of 4 or 5 weeks into this initial pilot study. Numbers fell significantly over the Christmas New Year period, and then we had a bit of a catch up again in January, February. At this point in time, those children who'd had their first HbA1c measurements done earlier were starting to become to get to their second HbA1c measurement, which was great. And what we really noticed was that there was a massive peak in the week before school restarted, as a lot of parents, given how much children had missed school, were very keen to get this measured just before school restarted. And so you can see our first test tailing off, but our second tests in red here picked up. There was a bit of a dip over Easter, And then what we really learned very much through this process was we had a lot of flux in our admin capacity, people leaving, people changing, and needing to train new admin staff. And what we really noticed was that because it was our admin staff who predominantly were booking all of these children in for their HbA1cs, that we really felt the effect of that change and that decreased admin capacity as our numbers getting tested each week really fell. And I think that was a big lesson we learned going forward. Once actually measuring our HbA1cs was sort of in progress and in hand, we moved to phase 2 of our project, which was then starting to look at ways of reducing our mean adjusted HbA1c. Obviously, having lots of children whose HbA1c is significantly above average, we thought of lots of ways to do it, but I think in the end we decided after discussion to focus on the newly diagnosed patients as the first people to try and instill good habits into, because what we'd very much noticed was that if we could get children and families following a routine at the beginning, they very much clung to that routine as they went forward. And so we thought if we could get them following good habits, we'd have a better hope of improving our HbA1c. So we introduced a new daily routine for a newly diagnosed, and I'll show you a picture of what we've done on the next slide. And we also then, in parallel, introduced our high HbA1c policy, adapting the East of England policy to our capabilities and availability. And for all patients, but especially on our newly diagnosed, we increased our focus on correcting high blood sugars. So we aim to audit this by analysing our HbA1c at 3, 6, 9 and 12 months in patients who are newly diagnosed from March 2021, which is when we started introducing our new daily routine. And we'll compare this to the HbA1c progression in children and young people newly diagnosed with type 1 over the previous 2 years, obviously because last year was affected enormously by COVID, so it may not be entirely representative. So we'll look at the previous year as well for comparison purposes. This was just an example of our new daily routine, which very much is an emphasis on checking and correcting sort of 2 hours after, so we get a much better idea of what their blood sugar levels are doing. And it's very much, we would like you to test, we would like you to correct. And it gives our newly diagnosed quite a clear plan of how we would go forward. So I think we just wanted to end with talking about the lessons that we've learned through this QI process. And I wanted to talk a couple in a bit more specifics about the things that we learned from especially the last couple of sessions. So in, I think, session 2, we very much talked about the 5 whys. And what we very much learned from that is as a team, we struggle at times to prioritize. What we found particularly was that we found time to develop new guidelines or update existing ones, as clinical priorities always seem to take over. So what we've now done is introduce protected time once a month specifically for guideline development. And I think actually just from the last couple of months where this has been introduced, we've noticed that we've started getting more feedback on the guidelines that have gone around, and people are making more progress in our updates. In session 3, there was very much the thinking hats technique, and that was really useful for us as a team to work out that another one of our issues was in terms of meeting deadlines. We were quite good at postponing our deadlines, and so what we've learned is to start breaking down our tasks into achievable chunks so that progress is made over time. And overall, through all the sessions, I think what we've very much learned is that while we have lots of ideas and lots of enthusiasm, we need to consider how to implement the changes that we come up with, and that process of implementation needs to be considered early on and included throughout the change process. Any questions?